Hey, good evening, everybody. Welcome back. I know a bunch of you have seen me lecture before, and I'm super grateful to Viva Learning for hosting yet another webinar. And of course, to tonight's sponsor, NSK, thank you guys so much for helping me put this together. I'm going to be talking to you guys about a topic that's very near and dear to my heart, but it's something that I don't get a chance to talk about too often, because I'm usually out talking about dentures and pros stuff, right? Because I'm a board certified prosthodontist. I'm also a lab technician. So that's the kind of stuff I generally tend to talk about, but none of that happens without, a lot of the behind the scenes sort of treatment planning and preparation of the patients to get them into a state where they can receive prosthetic care. So tonight we're going to be talking about CAMBRA. There's probably, I'm guessing, some people watching tonight that don't know what CAMBRA is. This might be something that's completely new to you. I am going into this presentation tonight with the assuming that some of you guys do know what CAMBRA is. If you've never heard that term CAMBRA before, again, at the end of this presentation, I'm going to have all of my contact details. Please reach out to me. I will send you any one of the dozens of papers that have been written about this topic. CAMBRA is an acronym, and it stands for Caries Management by Risk Assessment. You can see it right there on the slide. This was originally developed in the early 2000s by Featherstone et al. Out at University of Southern California, and it was put together for the general patient. There's been some updates, however, and especially the way that I do things in my office as a prosthodontist. I am going to go through some of my tips and tricks and some of the things, some of the tools, some of the implementations that I use for CAMBRA in my office. Now, many of you guys that know me, that follow me on social media, that have seen me lecture before, you guys know that I don't have a hygienist in my office. I don't even have an assistant. I am the prosthodontist, I'm the lab technician, I am the assistant, and I'm the hygienist. I do it all, okay? So this is something that for me, when you guys see these like beautiful before and afters that I post on Instagram, that I show at the symposiums, this is the foundation for everything, right? Because many of my patients, I see a lot of celebrity patients, I see a lot of international patients. If their hygiene isn't spot on, if their caries risk isn't minimized, if they are not taking good care of themselves, number one, I don't get oftentimes a second chance at getting that final photograph that I put in the publications that I give to companies to put in their brochures. I don't have good, multi-year follow-ups. And I'm going to give you a spoiler alert. I don't always have those. So tonight, what we're going to do is we're just going to go through, like I said, some of the things that I do in my office as a prosthodontist. Obviously, CAMBRA is a big topic. I can't cover everything here tonight. So like I said, I'm assuming that you guys do know a little bit about this. So why are we concerned with CAMBRA, and why should you be concerned with CAMBRA? Well, let's take a look at the life cycle of a tooth, right? And everybody's seen this before. If you've seen my lectures, right, I always show this. And this photograph was taken, this was an accident. I was taking this just in my daily documentation. But when you look at this tooth moving from right to left, right, you see a completely intact tooth. And as you move to the left, you start to see some of this accumulated bioburden, right? This is going to start to develop eventually into a class 5 lesion, which you see on tooth number 28 or 29, whichever one. It's hard to tell with so much wear and tear in these teeth which tooth that is. It's a premolar. That's all I can tell you. But obviously, there's been some recurrent decay. There's been a restoration. You can see there's like evidence of bruxism. And then what happens? You go back a little bit further, and now you've got a full coverage restoration, right? And that's got some decay at the margins. And then you keep going back even a little bit further, and the dentition has become completely hopeless. This patient has lost that tooth, right? And when you think about, at least in my office, when you think about the typical patient that's coming in for care, right? What does that patient look like? And this is really key, especially for you guys. For anybody out there, show of hands, who owns their own business, right? You should have in your mind's eye an avatar for who your ideal patient is, right? So maybe that's different for a general dentist. Maybe that's different for a cosmetic dentist. Maybe that's different for an endodontist or a pediatric dentist, right? So in my office, my ideal patient is probably somewhere between the ages of 60 and 75, right? They probably got kids out of the house. They're empty nesters. They're probably maybe widowers or recently divorced or something like that, right? They have some disposable income. They have a fair amount of vanity, right? But those are sort of some of like the external things. But what would you expect looking at these patients intraorally, right? You're gonna see things like tooth loss. You're gonna see a ton of crown and bridge, right? You're going to see a lot of recession, root exposure. They're going to be sensitive to hot and cold. And again, if these patients have things like, rheumatoid arthritis or any other autoimmune conditions, maybe they've got Sjogren's, they've got xerostomia, chances are they're going to have some sort of diminished skills in completing their oral hygiene, right? Like if you take a look at their hands, this is one of the first things I do when I'm shaking patients' hands, or, at least that was before the pandemic. Now, I always make an effort to look at my patients' hands to see if their knuckles look like they've got, a bunch of grapes underneath them, to see if, they've got arthritis in their hands. What's their manual dexterity like, right? So this is the typical pros patient. This is the typical person that comes into my office. So these are all the things that I have to consider. And, I hate to say it, as a prosthodontist, but the only thing that we do in dentistry that is 100% permanent is taking teeth out, right? If you live long enough, if our patients live long enough, and here in Maine, where I'm at, my wife and I, my wife's the practice manager, we have this saying that 90 is the new 60. Our patients are like, no joke, 300 years old. These patients are just living forever. There's something in the drinking water here, I swear. And so our patients live a long time. And so we're seeing these patients go on and on and on. And so I have to accept that responsibility. And the onus is now on me to, preserve the natural dentition that they have and make sure that, even though it behooves me and helps keep the lights on, I got to make sure that these patients don't get to a point where their teeth are all falling out. And here's the thing, right? When we're sitting down and we're drilling out our patients' teeth, and we do caries control, right? We all learn caries control in dental school, but what's the fact of caries control, right? And I don't like to admit this, but the truth of the matter is that you go in there, you remove all of the decay, right? You do all the fillings and you do the biomimetic style and you do the pretty rubber dam and you post the photos on Instagram and you get like 10,000 fire emojis, right? And it's all good. But this has almost zero clinical effect on the amount of bacteria that is living and thriving in your patient's mouth, right? This is a temporary thing. It's just a Band-Aid, right? I mean, how many times, do you see these patients come in, and these were some composites that I did for this patient, right? Like, what is this going to look like 36 months down the road? I guarantee it doesn't look like that photo on the right. I didn't take the follow-up photos, but I can tell you right now, it didn't look like this picture on the right. This is like same day. This patient often, and these patients, and here's what it is, at least in my office, we do these procedures and these patients just don't come back, right? They came to you for one thing. Hey, doc, I got these black spots on the teeth, and again, as a prosthodontist, I get a lot of referrals. So these patients are coming to me, it's kind of like a one-off sort of thing. So a lot of times these patients, aren't coming back. So in your offices, again, if you're like a general dentist, a pediatric dentist, making sure that you stay on top of these things is going to be critical, and letting the patients know, managing their expectations and letting them know that that handpiece that you're holding onto, that's not a magic wand, right? Your patients there's a lot of responsibility on your patients to be taking care of themselves too, right? And for, the pediatric dentists out there, I'm sure you guys have gone through this, speaking to the parents, right? And what we found out, through all of the CAMBRA studies, is that, whether it's the patients, if they're children, like this guy here in the chair, or whether you're talking to the parents, there's very little success in reducing what we call ECC, the early childhood caries, in groups that are going to be really, really high risk. All right. And so we're going to go through that a little bit. And so this is something that's like wildly frustrating, as a prosthodontist, again, because I see these patients over and over and over. And the running joke is that we're married to these patients. And I must sound like a broken record every time I talk to my patients and I said, if you follow my directions, I should go out of business. Right? I should never have to see you again. So on the one hand, the fact that there are these high-risk groups, that's what keeps me employed and well, so, right? It's unfortunate, and I don't like to be so realistic about it, but that's just the truth. And the other issue is compliance, right? Compliance is a major aspect of redoing dentistry, right? And a lot of studies have been done, and they found that on average, most patients, I guess most half of the patients will be completely non-compliant. And guess who's the worst? It's doctors, right? I mean, again, think about my type of practice. If you guys have seen my lectures before, who do you think can afford these full mouth rehabs? Who can afford a dozen implants, with like a hybrid type restoration, or, these telescopes with these removable dentures and MK1 bars and stuff? Who do you think can afford that? It's usually doctors. And the other thing is it's usually women doctors. And I don't want this to sound ageist or sexist, but it's older women who are physicians. And the reason is because they've spent their entire lives taking care of everybody else. They put themselves at the end of the line. And one day they wake up. And like I said, I have to think about who my avatar is, who's my ideal patient, who am I seeing? It's these women who are in their mid 60s to early 70s. They wake up one day, look at themselves in the mirror, and they say, oh my gosh, like my teeth are completely falling out. They're absolutely disgusting. I need to do something about this. And so when I get those patients, again, there's oftentimes not a lot that we can do. So I am very fortunate when I do get patients that are in their 20s and early 30s, because I feel like, okay, I finally have an opportunity to educate patients. And as a prosthodontist, I think probably 2/3 of what I do is not doing veneers and doing this cool dentistry that everybody thinks I do, right? It's actually educating the patient and talking to them until I'm blue in the face and can't spit anymore about taking care of their darn teeth, lest they want to, put my kids through college. All right. And so in order to get, the best long-term results and the best long-term prognosis, we really do have to treat the underlying caries process and educate our patients. And so there's several steps with this, with the caries risk assessment. And I'm going to go through this with you guys now. And again, this goes back to the Featherstone articles, from the original articles back from 2007, then the follow-up in 2011. And again, if you guys do not have those articles, happy to send it to you, happy to share with you. Hit me up afterwards, send me an email, shoot me a DM. I'll send you the PDF. You can take a look at it. All right. And ultimately what they say, and I'm sort of summarizing this, right, because of time, but ultimately the level of risk that your patient has when they enter your office, that's what's used to ultimately figure out, what kind of care you're going to give them, what kind of treatment, what kind of intervention you're going to give them. So, I mean, how do we determine risk, right? So there's two phases to this, and I do this for every patient every time. And it's not, I don't do this just for the people who come in that just want their teeth, or, sorry, let me back up. This isn't for the people who really need like a full mouth rehab. This is even for the people who found me, heard about me through a buddy, and they just want to get their teeth bleached before a wedding, right? I'm still doing this whole process for them. And if patients are not amenable to it, if they don't want to pay the extra money at the front, for the full mouth series of radiographs, for the full diagnostic workup, then they have to go elsewhere, right? Because at some point I do need to sleep at night. And this is how I do it, by going through these two different phases. So the first phase is I have to go through and I have to look at what are the disease indicators for this particular patient? What are this patient's risk factors? And what are the protective factors that I can use to make sure that whatever I do for this patient doesn't come back to haunt them, but more importantly, doesn't come back to haunt me, because I'm the first one that'll find out about it, right? And they'll let me know about it the day before Thanksgiving, the day before New Year's. I'm sure I'll know that their crown is failing, or that filling fell out or has recurrent decay, or whatever it is that they're in pain, right? So there's several caries disease indicators, and these just simply describe the clinical observation, right? These don't really say anything about why the caries happen. So I just want to make that clear, right? And we see this all the time with the cavitations, the white spots, radiolucencies, right? And these are just a few of the disease indicators. Here's the four, and this is, where you guys can do like the screenshot, So these are the things that I'm looking for, right? So when these patients come in, this is what I'm looking for, and I'm looking for it right away, because if the patient answers yes to this, and I give them a form, I have like a whole CAMBRA form that I have the patients fill out, and I have them sign, on there saying that I've gone through this with them at the end. And if they answer yes to any of these, they're automatically at a high risk and they go into my CAMBRA protocol, right? So if they have an obvious cavitation, right, that extends into the dentin radiographically, high risk. Usually on 99 out of 100 of my patients, I can just see a large hole in the tooth, right? I mean, it's not even like a judgment call. But also sometimes it's a little bit more subtle, is if you see proximal lesions on the radiographs, right? That's just in the enamel, and a lot of times we'll do the icon treatment for these. If it's just in enamel, right? The icon treatment is really, really great. If you guys don't know what icon is, I don't discuss it here, but let me know. If this was a full day course, that would be a great thing to talk about, but I don't go into it here. The visual white spots, like you saw in that last photograph, even on like smooth surfaces, right? And a lot of times this can be caused if the patient had like orthodontics, if they didn't have fluoridated water. A lot of times I ask the patients on my screening form is, hey, did you have well water growing up? Most patients in Maine check yes. This is why I'm doing very well in my business. Okay. So just make sure you look for that too. And then I also ask the patients, have you had any new restorations that could be fixed? It could be operative, placed within the last 36 months, within the last 3 years. That patient, again, is at an automatic high risk. And so I'm going to go over with you guys now some of the 9 caries risk factors. And these are just the biological factors that are really contributing to the overall level of risk. And this is going to help me determine, what is the risk for this patient for developing, tooth decay in the future. And this is really a great motivating factor for the patients as well. When you do all this stuff, and I know sometimes people are out there and they're thinking like, gosh, I don't want to like do this. It seems like a lot of effort, maybe the juice just isn't worth the squeeze. I'm telling you, man, this is the closest that I will get to fear mongering with my patients. I don't try to scare my patients into treatment. I don't sell treatment. I'm just honest with them. And again, it helps me sleep at night. And I tell you what, patients are interested in taking care of their teeth, right? And if you give them this information, you take some intraoral clinical photographs of this stuff, patients will come to you and get this treatment done. I think that this is the best way to get case acceptance. And I know there's a lot of courses out there that go through the whole process of, get great case acceptance, all these gurus on Instagram and Facebook. Like, that's nonsense, right? This is what you do. Go through the CAMBRA protocol, explain to your patients, inform them about what's going on, and they will get treatment with you. I guarantee it. So the number one risk factor, right? We're just like front loading this, is like medium and high strep mutans or lactobacilli counts, right? That's what's causing the tooth decay. The other things that, that might not be super obvious, like right from the beginning, a lot of times like some of this decay is only visualized on the radiographs, right? But this is something that you can see all the time: visibly heavy plaque and calculus buildup on the teeth. Now, sometimes it's not always this obvious. This is a patient of mine that I'm going to go through her treatment towards the end of this, right? But again, that's a major risk factor, right? And how did they get to this point? Usually from frequent snacking. And when I say frequent, I mean three times daily in between meals, right? And patients always lie about several things, right? Like how often they're snacking and how often they're brushing and flossing, right? But they think we don't know, but we do, right? Something else that I always look for are the deep pits and fissures. And I show this image because there's a few other things going on with this too. The large is maybe like putting it mildly, the gigantic bilateral tori here. That's an indication of grinding. That's pathognomonic for grinding, right? The grinding is going to be a big issue too. The tooth crowding, the anterior crowding, these are also in there with the deep pits and fissures. So don't ignore those either, right? Patients that are often grinding are really high stressed. And what do we know about patients that are super high stressed? They're often taking in highly refined carbohydrates and snacks. Go back to that one who's snacking frequently, right? And now you've got increased acid counts in the mouth, again, because of the increased levels of strep mutans and lactobacilli. And now all that acid's being produced, they've softened the enamel, they're running it down, and the teeth are going to break down really, really fast. Here's another one, again, that is really big in Maine, is recreational drug use. In Maine, we have a real big narcotics problem. We have we have a halfway house here. And the unfortunate and sad thing about like a halfway home is that most patients who are entered into a facility like that or self-refer, they do not make it through the whole program. And so these people get kind of returned back to circulation and daily life. And then they make their way into my clinic. And usually these things don't stop. And it's not even just, this photograph obviously shows like intravenous drug use and things like that. But one of the big things are things like Adderall, right? Patients here in Maine, especially younger patients, are really big on Adderall. And you'll notice this all the time because you'll see these class 5 lesions, right? And methamphetamines are also really big. So this also goes on my screening form. And a great way to find out if your patients are doing drugs is when I tell them, like, hey, I know you said you don't do any like recreational drug use, but I just want you to know there's like a 15% chance that your heart will stop when I give you some anesthesia if you did take drugs. Patients, now obviously that's not true. Patients will tell you every drug they've ever done for like the last like 10 years. Even that one time they got like high at their mom's house, like after church or something, they'll tell you everything. So I always kind of do something like that if I suspect that the patient is not being entirely forthcoming with me, just again, based on intraorally what I'm seeing. And speaking of intraoral, inadequate saliva flow by observation and measurement. And I'm going to go through later on how to do a saliva test. If you guys are not doing this in your office, I would highly recommend it. Saliva output is a major contributing factor, or I guess lack of saliva output is a major contributing factor to caries. We all know this. And I'm going to tell you some of the things that I do fairly routinely for my patients to increase that. And again, keep in mind, I'm seeing a lot of denture patients. Xerostomia is really, really high. Number one, because of the age. Number two, because of the laundry list of medications that they're on. And number three, a lot of them have had, cancer, tumors, things like that. They've had radiation therapy. Their salivary gland ducts look like raisins now, right? And that's okay. So yeah, here, I should have probably reviewed this ahead of time. So there, I got ahead of myself. But they've had radiation therapy. Again, that's not uncommon. Again, if you're a pediatric dentist, this is probably not going to be an issue. One of the other things, number 8 on this list, are exposed roots. Now, almost everybody in my practice has exposed roots, even the 20-year-old, Miss USA pageant contestants that come here that just want veneers, prior to the Miss USA, pageant. Everybody's got a little bit of exposed roots. I have exposed roots, right? So make sure you're looking at that. Now, most people don't look quite like this woman here, but it can be kind of bad. And then another one, again, speaking of pediatrics, and this is, this relates to my daughter as well. Orthodontic appliances, right? That is a risk factor. Now, again, I don't know if there are any orthodontists listening, or if there's any pediatric dentists. This is something I haven't looked up. I wonder if there are increased risk with, the traditional brackets that were bonded on versus, say, Invisalign, when they just got the little resin buttons on there, right? Like, I don't know. So as I'm saying this out loud now, I think I'm going to look that up. If somebody knows, what's the difference in, demineralization of the teeth and, cavitations like that, that'd be really something. If it's not out there, if there's not a paper, anybody here that's into research, let me know. Let's write that paper. That would be a great paper. All right. So those are generally the 9 caries risk factors. Now let's talk about some good news. Let's talk about some protective factors. All right. So these are things that are, of course, based on the history, your intraoral exam, and then again, some of the testing that we can do. And with the factors, a lot of times this comes down to things that you can do with the patients, some of the education, right? So one of the things that you can do, and this is super critical in my practice, is involving the patient in the discussion of not only the disease process, but the disease control. And there's a big ROI factor here too. Again, if you guys don't like to just hear yourself talk, and time is money, and you have a practice that's hustling and bustling, and you're hopping and popping, and you got to get this thing done. Consider that many of the things that I'm going to tell you are things that you can sell to the patients. You can upsell and make some money off of it. All right. Keep in mind, we are a for-profit industry. There's nothing wrong with making some money. All right. So obviously brushing daily, twice a day with a fluoridated toothpaste is great. One of the things that we do in our office is we sell electric toothbrushes. We get them for like $50 and some for like $100. Like that is just easy money right there. And my patients always ask me, once you've established yourself as an authority, once you've gone through this with them and show them that you really care, they're going to ask you, hey doc, which toothbrush do you use? I'll say, hey, you know what? Talk to my wife at the front desk. She's got one up there for you. She'll give you a good deal on it. Patients buy these all the time. It's easy money. I can make $50 just by telling the patient which toothbrush to use. All right. And then speaking of the toothbrush, if you guys have not seen this toothpaste before, now I don't speak for Plaque HD, but this toothpaste is amazing. This is like, if you guys have ever used, like the GC Tri-Gel, which I'm going to show later on, which, it's like the disclosing gel that you put in there. This is essentially disclosing toothpaste. You can rub a small bead on your teeth, swish it around with a brush, rinse and spit, and it'll show you where all the bacteria are. I use this with my kids all the time. My 7 and 11-year-old who tell me all the time that they brush their teeth and I can smell that they didn't. I threaten them with this toothpaste. I say, I'm going to disclose you in the bathroom. Like, okay, Papa, I did brush my teeth. Jeez. And then they go do it. This toothpaste is amazing. And I give this to the patients because they always used to ask me for my GC Tri-Gel, and I had to order it. And I didn't even know if I was allowed to give it out. So this is awesome for your patients. And I sell this for $30 a tube and they love it. So check that out. The other thing is the fluoride varnish, of course, right? And this isn't built into my, my hygiene routine. This is an extra $8 or $9. It's not free, right? So if you have your hygienist there and you're giving this stuff away for free, no, man, you got to charge for that. That's a consumable. They better pay for it. Get paid. Like I said, this is a business. But definitely do this fluoride varnish for your patients 3 times a year. And if you have some patients we have some kind of nutty patients who aren't really into the fluoride thing, educate them about that. All right. And now something that's going to be a little bit more difficult is going to be the drinking water. Now, if again, certain places in Maine, it's very rural, we don't have fluoride in the drinking water. All right. So again, that's why it's going to be super critical to do the varnish, to make sure that your patients aren't using some non-fluoridated toothpaste. Right? Make good recommendations to them. Something that many people don't know about is the use of chlorhexidine, right? And you can use Paradex or any, Henry Schein makes a brand, it doesn't really matter. But using this for daily use is not something that you want to do. Anybody who's ever done that, who's ever had surgery like me, with an implant, your teeth turn brown, the temps turn brown, right? But you can give chlorhexidine rinse to be used daily for 1 week per month for some of your patients that are going to be at high risk. And this really, really helps. And again, when they do this, their teeth will start to get a little bit dingy. It'll encourage them to come back to you, for their prophies and stuff. And again, buy the Paradex and sell it to them, right? And make profit off of it. Something else that you can have that we have, at our front desk is xylitol gum. Right? You can get Spry or Spree or whatever that is, or any brand of gum. It really doesn't matter. The most important thing is that you encourage your patients to chew the gum, not only because it has the xylitol in there, but it stimulates saliva flow, which we've obviously said is not really, really great. And you want to give them either the gum, some people don't like gum, or you can give them the lozenges, right? And you want to do that 2 times per day for at least 15 minutes. And the key is you want to get 7 to 10 grams total. Obviously, or maybe not obviously, but if anybody's never chewed xylitol gum before, you guys don't know, it can cause some gastro issues, and you could get diarrhea if you have enough of this. All right. Some people that are always chewing gum, right? They'll overdo it and they'll get a little runny later on. Okay. I don't think I need to say too much more than that. Other protective factors, and now I do speak for GC America, so I don't mean for this to be an ad for them, but this stuff is amazing. If you guys aren't using MI Paste, you got to get on board with this. This is an amorphous calcium phosphate. Have your patients use this 2 times per day following the regular at-home routine. Again, with a fluoridated toothpaste. All of the studies show that this stuff really, really helps protect teeth, helps to remineralize some of those teeth. Like when my wife got pregnant with our first couple kids, she again was taking in increased carbohydrates. She had small little lesions here and there. She was using this stuff like it was going out of style. When she came back in for her checkup after the kids were born, everything had healed. Everything was gone. There's no more sticks, no more visible lesions at all. All right. Now, again, many of your patients will have dry mouth, and I am not a big, I'll talk about this in a second. I'm not a real big fan of like Biotene and some of these over-the-counter things. I am a big fan of Saligen, which is also known as pilocarpine. Some of you have maybe heard of like Evozac, which is cevimeline. I can never say that. But this is really, really great for your patients. And I'll let you know how to tell if they need this or not. And I will caution you, I don't ever just prescribe this without discussing it with their primary care physician first. So make sure you call the primary care physician. You don't want to give them this if they've got, some issue or some other medication that they shouldn't be taking this. And now I mentioned Biotene. Again, I have yet to find a patient who's like, yeah, I really like Biotene, right? Essentially, this is just a buffering agent. It's a saliva substitute. Most patients really don't like it. Like I said, I haven't met anybody that likes it. And at the last minute, I added this in, the povidone iodine. This was a really big thing during the pandemic, right? Maybe some of you guys use this. There's many products out there, like IoRinse is like one of them, right? This RTU, which stands for ready to use. This is not recommended for helping your patients with like day-to-day bacteria. What it is useful for is for controlling, intraoral bacteria right before your dental appointment. So I will have my patients rinse with this, but not to control the bacteria for oral hygiene. It's to kill COVID, right? And any other types of pathogens that are in there so that I'm not surrounded by a cloud of, SARS, essentially. That's what it's useful for, but I don't give this to my patients to take home for hygiene issue. All right. As we move into phase 2, this is where your clinical judgment really comes into play. So for new or recent graduates, this is going to be a little bit more difficult until you're really, really comfortable around patients, until you've seen enough of your own work come back, until you've seen enough of these patients, for like 5 years, 6 years, 7-year recall. This is going to be tough to do because it is judgment-based. And I really highly recommend that you find mentors. You shadow some people and you kind of see what's going on with this. But in phase 2, we're essentially trying to determine the level of risk that's going to be the sum of these factors, right? So let me kind of explain here. So, for example, and this is my poor daughter, and anybody who has teenage kids, this is her even before she was a teenager. Maybe she was like 10 here. This is what my daughter calls tooth shaming, right? So before I was using that, that toothpaste, the disclosing toothpaste, the Plaque HD, I would take my Tri-Gel home and I would like brush on my kids' teeth with a microbrush after they told me they brushed their teeth. And I was like, no, you definitely haven't. So my daughter calls this tooth shaming. And so, for example, my daughter actually has no cavities, surprisingly. I don't know, right? But so, for example, a young patient with poor hygiene, like my daughter here, but no other risk factors, this patient is not going to be at high risk. So just because somebody has poor hygiene does not necessarily put them at high risk, right? And this is, again, where this judgment-based decision comes in. However, the instant that you notice a single cavitated carious lesion, like you see here on tooth number 14, now this patient had, some old fillings back on 15, probably, like 12, 13 years ago. And they now have a new restoration here. You can see they've also had some acid attack going on in their teeth, right? They have some other things going on. They are now immediately at high risk because caries begets more caries, all right? So what I'm gonna do is I am going to go through some of my recommendations, right? So that's what people wanna know is like, what do I use, man? All right, so I am going to go through a list of 9 recommendations. And this is what I do with all of my patients that come in. So when my patients come to me for my, the initial visit, I always put them on a caries reduction program. Sometimes you call this like caries control, right? I usually don't say that. I call it a program. Patients like to think they're on a program, right? And I do that like during and following PROS treatment, right? And I always discuss this with the patient before initiating. And I thought that should go without saying, right? You would obviously discuss this with the patient before you start drilling your teeth. But again, I get a lot of patients coming from other offices where they said, yeah, the doctor never told them what they were doing. They just started drilling teeth. So again, it should be obvious, but of course, I encourage all of my patients to brush with a fluoridated toothpaste at least twice daily. And if my patients, give me some line about, well, they're not really into fluoride, I tell them to go elsewhere. I won't even treat them. Like I'm not into the nonsense. I'm not gonna tolerate it. And the thing is I don't need the money. I'm at a point now where I don't really need the money to do it. So I'm happy to say no, because I am going to be the last monkey, since I was the last monkey in there. If and when, and I think it's a when, not even an if, when those teeth fail and restorations start breaking down, I'm going to be the one to blame. The patients rarely ever take ownership of their condition, right? And any of my patients, I generally do this for everybody, but especially if they have a lot of recession, right? If you can see the roots exposed, they're getting a fluoride varnish 3 times a year. And again, I am charging for that. I'm selling the patients the toothpaste. I'm selling them the toothbrush, right? I give them like a whole package. And that's why I call this a program. They like to think that they've got somebody caring for them, right? And then same thing with the chlorhexidine, right? I'll have the patients use it for a week out of every month, right? And again, if nothing else, this really encourages them to get back in, because when it starts to stain their teeth a little bit, they come right back to you. Again, I give them the xylitol gum, which I sell to them, explain to them how long to chew it, what dosage. Patients, my elderly patients, and this isn't even everybody that's elderly. I have 20-year-olds that have partials, right? That's actually really sad. But my patients that have RDPs, removable dental prosthetics, also dentures, most of my denture patients have denture stomatitis. They've come to me with a 35-year-old denture. Their nose is almost touching their chin. They look like Mr. Magoo, right? They've got angular colitis. They've got denture stomatitis. They're sleeping with their dentures, right? I give my denture patients gum, right? And a lot of people think, oh, should you give denture patients gum? Absolutely. It's not going to stick to the denture. Trust me. Everybody thinks like, won't it stick to the acrylic? No, it doesn't stick to the acrylic, right? So I have them use xylitol gum, and I have them rinse with the chlorhexidine rinse as well. So this isn't just for your dentate patients. This is pretty much everybody. Going back to that GC, like MI1 paste, right? I'm having them use this twice a day, and they can apply it with a cotton swab. They can put it on their finger. Custom trays are even better, right? Because I'll charge $300 an arch to make them a custom tray. The only issue with a custom tray is that, again, like many of my patients, they're getting crown and bridge like every other day. So I'm constantly changing that out, right? Frequent sipping of water. I tell my patients they should carry a jug of water around, like those wrestlers in like high school that were trying to like gain just like a little bit of weight so they could, or sorry, not the wrestlers, like the guys on the rowing team, when I was on the rowing team, right? So, and then you like quickly like drop the weight, right? So they should be sipping water like all day long. They can even mix 2 teaspoons of baking soda in there, right? A little bit of water to help neutralize the acids, right? The sodium bicarbonate that's in there, it's the same thing like the calcium phosphate that's in your saliva, right? These are just great buffering solutions. And then the salivary flow rate, and you can even do bacterial testing if you want. I honestly don't do bacterial testing. Ivoclar makes a test. It's called the CRT kit. I don't do that. I did it in the residency to check the box and say I did it, but I usually don't do that. One of the things that I do is, and you need to give your patients a carrot. You need to give them some reason to focus on hygiene. Now, most patients think that oral hygiene is kind of boring, and investing in that is not really useful. So when patients come to me and they look like this, and you can see a sweater of plaque on their teeth, I have them bleach their teeth, and I make custom bleaching trays for them. If you guys have seen my bleaching lecture here, you know how I do this, right? So this is my daughter again. This is just about the only way I get her to clean her teeth, right? Is I make her, I can make them custom bleaching trays. My daughter is using Invisalign. So I give her some 10% carbamide peroxide. She puts it in her Invisalign trays, right? And she's got these little buttons in there. And when they put it in, it oozes onto the tissue. This 10% carbamide peroxide is safe. It has a hydrogen peroxide content of about 3%, which is less than the body makes every single day. So this is great. Again, if you're a pediatric dentist, doesn't matter who you are. I use this. Every one of my patients gets 10% carbamide peroxide as well. You won't find that in the CAMBRA literature. That's something very specific that I do in my office. And also we see a lot of patients with failing implants. If you've ever seen any of my implant lectures, you know I do this as well. If you take a look, these are two different patients. Look at how clean those threads are. How do you think these patients keep those implants that clean? It's because in their dentures, I give them carbamide peroxide and they inject it into their dentures. They inject it into the little locators and around the housings of whatever attachments that they have. And their implants that are failing, their abutments stay sparkling clean, right? So, and again, bleach is expensive for the patient, not for me. I mean, it's cost me next to nothing. And I charge the patient like 25, 30 bucks a tube, right? And this is something that they use over and over again. All right. Now let's talk about like some fixed prosthetics, right? So with fixed prosthetics, CAMBRA is super important. And if you guys saw my tooth prep lecture, you guys know about this, right? So fixed prosthetics fail all the time. And one of the major reasons is recurrent decay around the abutments, right? So the patients got to this position for a reason. They probably weren't taking care of their teeth. And what do you think they're going to start using super floss underneath their denture, underneath their bridge? Rarely do they ever do that, right? So, and this is a big, big problem. And I won't talk about this too much, but usually this is like basically every patient that comes into my office that has a bridge that failed. There's hardly any tooth left underneath this thing, right? I got to get something on there to get them out the door, right? I can't just carve away all the decay. I got to like drop the margins on these things. And so this was, again, this is part of a whole other presentation, but I just wanted to stress, this is how I actually get these attempts back on to get them into something. And for those of you that saw me speak on this before, you'll know that these are these NSK handpieces, and I am in love with their electric handpieces. And we did a webinar for this with the mommy dentist in business, where we talked about the electric handpieces. And one of the things about these handpieces that I really, really like is that there's a ton of torque on these. There's not a lot of aerosols, which is really, really important now during the pandemic time. I'm not going to go into this like too much here because I want to focus on the CAMBRA stuff. But let me just go and show you real quick. So something that I do want to point out when you guys are doing fixed prosthetics, right? So this is a bridge that we did for this nice lady. That's 6, 7, and 8. Number 7 is the Pontic there. She's got, that's some pink porcelain that you see, right? And it's really, really important to stress the ability for patients to use superfloss. I can't tell you how many of my patients tell me that they've never heard of superfloss before. Like this woman had a bridge prior that fell off. We put this one back on. And she said the previous dentist never showed her how to use superfloss, you know, so it's a little surprise why this fell off and why there was decay, right? And so usually this is what I see. This is the kind of stuff that walks into my office pretty much every single day, where the patients have a temporary on. They came to me looking for a second opinion. You know, they heard that I was a prosthodontist and the bridge that they had is really hurting them. They don't know why. Could I take a look at it? And this is the kind of stuff that I see all the time. I see these like bridge lap, Pontics, excess cement, right? The previous dentist did not contour that Pontic site well enough. They are not stacking the deck for their patient for the hygiene and for the CAMBRA going forward, right? And one of the things, and I just wanted to throw this in there, that if you guys are unfamiliar with this, you should probably not be doing bridges like this, right? But this is how I do my Pontic design. I just want to throw this in there. Again, this is from another lecture, but I use this KS5 burr to develop that Pontic. I do it without any anesthesia. This is what this needs to look like to develop really optimal hygienic prosthetic for your patient. And I will tell you that even though I do this all the time for my patients, there's no guarantee that the things that you do, you know, bending over backwards for your patients is absolutely going to help them out all the time. So this is Sharon. This is one of my most well-known cases. Anybody that's ever seen me lecture, you've probably seen this case. And I'm going to pull back the curtain here a little bit. So you can see with Sharon, you know, she's missing some teeth. Sharon is at extremely high risk. All right. Now this was years ago. This was done back in like 2017. Then you can see she's got some recurrent decay on number 9. She's lost number 7. She's got root exposure. She's got missing teeth. She's got existing crowns. Sharon is typical high-risk patient. I did not do the CAMBRA protocol with Sharon when I first saw her. I was so focused on making her bridge look really great. You know, I was like so hardcore about, you know, the shade and the shape. And the cement we were using and making this thing look great. Obviously, I tried my best to make a hygienic, Pontic and to work on the occlusion and, to educate Sharon about taking care of the teeth. But at the time, it was really just like a lot of lip service. Like I didn't like believe it. And we did this case when we first opened our practice, and within about 3 years, so right around like end of 2019, like, just before the pandemic hit, Sharon had come back in, and within just a very short period of time, this is what her teeth looked like, right? And so Sharon has xerostomia-induced class 5 lesions here. It's throughout. It's not even just here. And so in hindsight, what I would have done is I really should have done these salivary flow rates for her. I should have incorporated this whole CAMBRA protocol with her, and I just ignored it. And so if you guys are frustrated in your practice of seeing the same patients like over and over again, coming back with this stuff, really, really take a look at some of these things that I'm going over with you guys now. And so the way that I do the salivary flow rate test is really, really simple. I basically give the patient like a little piece of like paraffin wax. They chew on it a little bit. It's flavorless, and they start to salivate right away, right? And then what I have them do, and there's really no dignity involved with this, but they spit into like this little measuring cup, this little graduated cylinder, right? And they do this for about 3 to 5 minutes. And it's measuring essentially the saliva in millimeters per minute based on stimulated saliva flow. So what does this mean, right? So if they have 1 millimeter per minute and above, that's normal, okay? That's what you want to see. If they have somewhere in the range of, like 0.7, 0.75 millimeters per minute or less, that's low, all right? If they have a 0.5 millimeter or less, that's not good, man. That is like severe salivary hypofunction. Sharon has severe salivary hypofunction, and this is something that I did not address at the time. And now I'm having to go back and do more work on her again because I didn't recognize that in the beginning. All right. So this is how you do the salivary flow rate. It's super easy to do. It takes just a minute or two of time. You can have your staff do it. Like really anybody can do this. And the thing is, old habits die hard, right? So again, I've said this before, is that many of these patients are in this situation because they didn't take care of their teeth the first time around. It's difficult for them to take care of their teeth, the second time. So we have to sort of be like their guardians. And I know, as healthcare professionals, we got into this with this whole idea of like doing no harm and, we're going to take care of patients. But again, I'm using some of these cases as words of caution. Like, don't be like me and like say that you care about the oral health, but you really don't. You know what I mean? Or you do just as long, just for the, 9 to 5 that you're at the office, and then you stop caring about it after that. So something I did not have time to really go into today is about treating patients with CAMBRA that have severe amounts of dental erosion. And I always offer this book up. I have a monograph, this one by Lissy. Shoot me a message. I will send you this monograph afterwards. If you have no idea how to treat patients that have severe acid erosion on their teeth, this monograph will definitely help you out. Tells you how to diagnose it, how to treat it. And a lot of these CAMBRA protocols are in there. All right, moving from fixed, we'll go into removal. This is something that is very, near and dear to my heart. These studies that were done back in the 80s, this is something that's been known for a long time. Anytime your patients have a partial and they've got the abutment tooth, that abutment tooth is at least, this says 2 times as much, but recent studies show it's probably even more than that, at least 2 times as susceptible to decay. All right, that number goes down if they have a crown on that tooth, but then the numbers go back up if they have recession. So I know I sound like a broken record when I say this in my office. I don't do plastic in my office. I don't do partials in my office. These were patients that had existing partials, right? And my thought is that, this patient, this only ends one way. He's already had his top teeth taken out, and that was like within a day or two. And I decided to take this photo, and I'm like, his bottom teeth, he's already got a partial on the bottom. He's got a lot of recession around those teeth. He's got some teeth kind of rotting out in the front here. This guy will be in a complete denture in no time at all. And I always say that, partials are a slow, painful, and expensive way to get your patients into a complete denture. I do not like partials. I do not like having my patients go this route. It goes that way, unfortunately. So for those of you that are wondering, I don't do partials. And speaking of edentulating your patients, this is the kind of stuff I see again, too. And now, again, this is a patient that, did not have the disease process explained to them, did not have any of the risk factors really looked at. And this is the kind of stuff, again, that I see all the time. This woman came to me. She was treated by some guru somewhere in New York City, and she was having some pain under her lower denture and, you know, some issues on top. And I noticed some bleeding. And this is why I almost never do fixed cases anymore, because it's impossible for the patient to clean. So here is, this is Jessica. She's a super nice girl. She came to me and she had a wedding emergency, and she had a 15-year-old partial denture in place. And yeah, it looks like it was 15 years old, right? Like one of the teeth had broken off. I mean, it really looked like a practical joke. And the thing is, it's so sad, is she's such a sweet girl. And nobody should have to go through this, right? And again, this is just another instance of where the clinician just really neglected to explain to her the disease process and to show her what could be done. So I'm going to show you, I'm going to finish showing you her case. I'm going to show you a little video now that kind of showcases some of the products that I use. Like when these patients come in, again, I'm doing all the hygiene myself. And I have sort of what I call like the big three. I have several tools and implements that I use on every patient, every time. You know, this is an NSK sponsored presentation. So of course I'm using everything that's NSK, but not just because they're sponsoring me, it's because their stuff is really, really the best stuff. So I'm going to show you just basically like a typical day when a patient walks in. You know, we had a new patient come in, you know, a couple of weeks ago. I told them, say, hey, block off like 2 hours. I'm going to do full consult, full radiographs and full debridement on you. And so I'm going to kind of show you what goes into that. So this was a guy, he had not been to the dentist in about 15 years. Okay. So when he comes in, you know, we're a high-end practice and we book out really, really far. So I don't like to bring people in for consult and then bring them back for a cleaning later on. I like to get these people in. I like to get their cleaning done. And really, this really helps me build rapport with these patients, really helps get them on board, really shows them that I care. And a big part of this is education. Now, some of the things that were in this video I'm going to talk about here. This is the Profimate Neo. I have only really started using this within the last couple of months. This was not something that I'd ever used. I'd never used one of these air-powered tooth polishing systems before. If you have not tried this, I am completely hooked on this thing now. If you guys, again, like a lot of these patients of mine that have, you know, these big black triangles, rotated teeth, and if you're using you know, like a piezo scaler or ultrasonic scaler, whatever, and you just can't seem to get in all those little nooks and crannies, this will do it. All right. And it's super great. It's got a really easy connection. It's completely autoclavable, and it has this, what they call like this flash pearl powder in there, and it's calcium carbonate. And one of the things that patients told me, I have not tried this myself. I haven't tried it on myself yet. But the thing that the patients tell me all the time is that it doesn't taste salty. Most of my patients, I will split between myself and a periodontist, right? So they'll see me maybe twice a year. Like I'm seeing many of these patients on a quarterly basis. So they'll see me twice a year. They'll see the periodontist twice a year. And the hygienist that treats them at the periodontist office, they say that they hate the taste of whatever the perio hygienist is using. They're like, it tastes salty, it tastes like fish. They're like, they really like this stuff. So maybe I got to tell my periodontist about this. But they really, really like this stuff. And it comes in this super easy to fill chamber and these like really nice disposable convenient packages. And there's a couple different tips with this. In that video, you saw me using the 6-degree tip. As I get towards the posterior, if they've got really steep, deep cusps, which again, some of these patients are going to have, right? Then I'll use this 80-degree tip that's kind of like a little bit more, it's more horizontal to the occlusal plane of the teeth. And so with Jessica's case here, right, that's what I use, is really, really nice. She was really, really sensitive on this tooth. And that's the other thing, like this air powered spray, it doesn't cause a lot of sensitivity. So if you have patients that are really sensitive to having, the ultrasonic or piezo electric, whatever, used on them, try this. I have yet to have a patient say like, ow, it hurts, right? So it's really gentle on the gingiva. You don't point it right at the gingiva, but it's really, really nice for doing these delicate little sensitive areas. And now if you guys recall what Jessica looked like from the lingual, right? She's got some bone loss. She's got this giant, almost looks like a, I don't know, tumor back here growing. It's pretty massive, right? Sometimes you need just a little bit more. So the device that you saw me using in the beginning, that was the Varios 970, and that's a piezo scaler. I have switched now. I used to use like a Cavitron. I used to use a few other things. This is awesome. Like this thing is so good. And I think I spoke to the folks at NSK today, one of my friends at NSK. I was telling her like how much I like this thing. I need to order more of these tips. I'm like completely hooked on this thing. And sorry, so here's the way that this looks right after. Let me go back. So one of the nice things I like about this is too, so I'll have water on one side and I will switch containers. So for some of these patients that have a lot of deep pockets, I'll go to like a chlorhexidine and I'll just like blast that in there and really, really irrigate that out, right? So that's the way that this looks like right afterwards, right? And so sometimes I just get in there and I do some good spring cleaning. Then the very end, you saw me using the iProfi Air. This thing is really, really amazing. And now if you're not doing your own hygiene, you wouldn't know. But ask your hygienist. They get a ton of hand fatigue. I know, because I'll do like 4 or 5 cleanings like a day sometimes. And with regular hand pieces that are like really long, or they're kind of heavy, they're not super ergonomic, right? You get a ton of hand fatigue. And the other thing is too, like these are so whisper quiet. I've always got my music playing and I like to just zone out and listen to my music. And these things, you can barely hear them. And if you do have a bunch of hygienists in your office or you're not doing your own, they have these little rings that you can attach to here. I like the purple because purple is like my color, man. It's the color of dentistry. So I like purple. That's the one I use on mine all the time. But they have these other little rings so each team member can have their own color. And it's really, really nice. So here's the way that Jessica started out. And here's the final result, right? And this is ultimately what we're going for, right? We want our patients to be really, really happy. We want our patients to be healthy, right? Most patients are happy when they get the final result like this and they think, yeah, this looks awesome and I'm ready for my wedding. And, you managed to do this in a couple days, right? And so the thing is, again, I just want you guys to remember as we conclude this up here, is that there's a lot of reasons to do CAMBRA. And I really would make me feel good if you guys would read some of the papers, reach out to me. I want to send you these papers, like read into it. Like, I can really only touch on a few of the protocols and the things that I do just in my office. And I've kind of mentioned some of the things that I use in my office that are not used elsewhere, right? And there's ethical reasons, legal reasons. One of the big ones for me is the standard of care issue. But the most important, obviously, is going to be the benefit to the patient. And I think you guys will find that it's a very rewarding protocol to go through. So guys, I wanted to thank you for spending an hour with me tonight. Hopefully I didn't go too far over. Thank you to NSK. Thank you to Viva Learning for hosting this. Again, a very different topic than what I'm used to presenting. Guys, here's my Instagram handle, and there is my website if you guys want to get in touch with me and you want any of the PDFs that I talked about today. And if there's any questions, I will take those now. Let's see. Okay. Okay, Kevin, I will send you those. Kevin, shoot me. Okay, I'm going to try to take a snapshot of your email. Kevin, I will send you those articles. You got it, man. George, how are you? Hope you're doing well. Somebody asked me, how come I don't have a hygienist or dental assistant in my office? That's a great question. I'll tell you why I don't have a hygienist or a dental assistant. So I'm a KOL, which is a key opinion leader, and I speak for many, many different companies. And because of that, it requires me to be on the road so often. Having a hygienist or assistant here, my overhead would be tremendous if I was out of the office constantly. And at least in the state of Maine, the rules for what hygienists are allowed to do, I don't even know, to be honest with you, if a hygienist can. Yeah, I guess they have hygienists. They do have hygienists that can work independently, but you need certain certifications and things like that. So it would just tie me more to having to be in my office all the time. That's pretty much that's why I don't. And the assistant thing, I've learned how to work solo without an assistant, either through the use of rubber dam or like something like an isolite or any kind of thing like that. Many of the implant procedures are really easy to do. If you guys have ever seen me talk about implants, I have the patient help me out with a lot of this stuff. I am not trying to take away from a really great assistant. Assistants are absolutely wonderful. I have tons of respect for the assistants. Just in our office with the type of stuff that we're doing, a lot of times with dentures, I don't need an assistant with like dentures at all, or, the cleanings. And also too, with the cleanings that we do I know a lot of people think that hygiene is like a loss, right? You're taking a loss, you're taking a hit with hygiene, right? Especially in Maine, like it started snowing today. We're getting like a nor'easter coming through, I think. So a lot of our patients, we have a lot of cancellations. We have a lot of last minute cancellations due to like the weather. And so if you have multiple hygienists in your office or any type of hygienist or assistant and people can't get into work, that's a bad day. So I just don't like losing money. And with me doing the hygiene myself, again, I'm upselling a lot of that. I'm making custom trays with the bleach. So, and I charge a lot for my cleanings. I'm charging like $250 for my cleanings. And most of the patients who come to me and have the cleaning done with me, they never want to go back to the hygienist. I use 4-power loops when I do this. They love all of the products that I use. They love the education that I give them. And it's rare that I ever have a patient tell me that they haven't heard things. The things that I tell them, they've never heard it before. And these patients, it helps build that rapport. It helps build that trust. And I could do just about any procedure I want on these patients. When I tell them like, hey, you need a crown, you need a bridge, you need a whatever, they're like, yeah, I'm in. They want to do it. They're on board. So there's a lot of reasons for that. So I hope that answered some of your questions. And hopefully I didn't go too much on a tangent. Do you charge extra for cleanings with the system you use since no hygienist? 100%. Yes, I do. I charge a lot for the cleanings. Like I said, I have a lot of really, really cool instrumentation like I showed you guys at the end. And most of my patients, and I also do hand scaling too. I didn't want to bore you guys with like the hand scaling. I just want to show you some of the things that I use, kind of like my powerhouse, my dream team of products that I use. Most of my patients tell me that they've never seen a scaler, like a piezo scaler like I've used before. It's like the first time they've ever seen it. And now they can't go back, right? They can't go back. It's like the difference between taking like a shower with like really intense like water pressure versus like just standing in the rain to get clean, right? Like they can't go back. And the same thing with that ProfiMate Neo. That ProfiMate Neo, I thought I was pretty slick before with like the piezo electric, the piezo scalers, like the ProfiMate Neo, that air powered polishing. Patients think that is like the greatest thing. And they've had stains. I've had patients tell me that I've been able to get rid of stains on composites that they've had since they were like teenagers. And this is the first time they've ever seen their composites look clean. I've had patients tell me that dentists wanted to like remove the composites because they were like recurrent decay and it wasn't. And I'm just telling you, these products, and again, I know this is an NSK sponsored like presentation, but even if NSK fired me today, I would buy stock in these products. So let's see. I think there's some more questions here. Okay, so let's see. Stain deeply below surface. Okay, so Bob, that's a great question. So Bob said recently had a patient with white spots who was treated with chlorhexidine after extractions. The white spots were stained deeply below the surface. Best way to treat? Really, really good question. There is a product, and again, this isn't an Ultradent lecture, obviously, but this is a product that I use. It's called Opal Luster. And I think the luster is spelled like the British way. It's like Lustre, opal, OPAL, opal luster. And it's a purple like grit. It looks like a prophy paste, but it comes in like a little tube. And it's like an acid, it's like a mild acid slurry, coarse grit slurry that you put on white spots, that you put on, mottled teeth, that you put on some of this like demineralized things. And you do it with a rubber dam. Make sure you do it with a rubber dam. And if you look on my Instagram, I have a case that I did with this. If you scroll back, maybe a couple months, there's a case where I did this, where I've got a black rubber dam on this woman, and she had a big white lesion like that. Same thing, she'd say it would stain after she'd drink coffee and stuff. She didn't like it on tooth number 9. Without any anesthesia or anything, I just buffed it out. And then we tried the Icon system. Again, if you don't know Icon, that's made by DMG, makes Icon. Then you can do Icon on there, which is the infiltration system where you infiltrate with like a flowable, or what is it, non-filled resin, clear resin, and use some ethanol to kind of draw out some of the moisture and things like that. So check out Opal Luster, check out Icon. That's what I would do. Roxana, contact me about the Plaque HD toothpaste. I honestly have to look that up. My wife is the one that orders all of this stuff. I'm just the dentist, man. Well, dentist slash hygienist. I don't know where that is. My wife has the contact details for all. My wife is the smart one. So she's the one that talks to all these companies. If you send me an email, if you go to my webpage or find me on Instagram or something there, shoot me your details. I will get you, I'll get you that information. See. Let's see. Okay. Any more questions? Thank you guys for the answers, or for the question. And Cornelius. Yes, I like that toothpaste as well. Okay. Awesome. Yeah, if you guys could give me your just shoot me your email. Get me your email. I will get you that information.